Welcome, and thank you for tuning in for North York General's House Calls, a conversation with our community. I'm Nicole German, Chair of the Foundation Board, and I'm excited to host the fourth in our series. I hope all of you and your families are well and keeping safe. An educational evening awaits with Virtually Yours in a COVID world. But before we get started, I'd like to encourage you to submit your questions for the panel through the Q&A function of Zoom. We will be pausing every so often to take some of these questions and also those that were submitted prior to this evening. I now have the privilege of introducing our panel. Many of you will recognize Dr. Donna McRitchie, who is the Vice President of Medical and Academic Affairs with oversight of research, innovation, and education. She is a highly regarded general surgeon and an intensivist in our critical care unit. Tonight, we are pleased that Dr. McRitchie will address virtual care from a corporate standpoint, the pivots in surgery, and perhaps delve into research and clinical trials. We look forward to your unique perspectives, given your multifaceted role at North York General. Welcome, Dr. McRitchie.
Thank you so much, Nicole. It's a pleasure to be here.
A warm welcome to Dr. Phil Shin, Chief of Medicine and the Medical Director of Critical Care. Dr. Shin restructured his department and developed program-wide protocols in response to the COVID-19 onslaught. During this challenging time, the medicine program's physicians and staff have implemented new standards in patient care, including the rapid adoption of virtual technology to better manage constant change. Dr. Shin will be speaking from an overall medicine perspective, covering North York General's outpatient clinics, ICU, and elder care. Welcome, Dr. Shin.
Thanks, Nicole. I'm really pleased to be here and looking forward to a great discussion.
Thanks. Our panel on virtual care wouldn't be complete without a conversation that includes the children in our community that are affected both overtly and quietly by this pandemic. And who better to guide us through this dialogue than Dr. Rhonda Kanani, Chief of Pediatrics and Co-Medical Director of the Maternal, Newborn, and Pediatric Program. Dr. Kanani is one of the many incredible specialists associated with our hospital and will be sharing how virtual care supports inpatients and a number of clinics, including one dedicated to COVID-positive patients. Welcome, Dr. Kanani.
Thank you, Nicole. It's a pleasure to be here.
Behind the scenes is our moderator, Christine Lasky, Vice President of Communications and Donor Experience, who will be asking our panelists questions via audio only.
Thanks, Nicole. It's wonderful to be here, and we have some great questions from the community tonight.
Looking forward to it. Can you believe that now 60% of primary care is done virtually? You may then ask yourself, how much of our care is being done virtually at the hospital? Dr. McRitchie is here to answer that question and more. Dr. McRitchie?
So thank you, Nicole. And really, first of all, thank you to you, Nicole, and to the Foundation for inviting us tonight and for supporting this event. And really, I wanted to start by also thanking our community and the people that are participating tonight on this call. You know, it's so important to have support for the work that we do and for validating the work that we do. And it has been a bit of a long haul over the last many months. And the fact that we have so many people giving us a bit of a shout out and supporting us has made a huge difference. And things have changed a lot, actually. And from a corporate point of view, we've shifted very significantly from where we were just 10 months ago. The whole pace of change has really changed dramatically and really revved up. And while we knew we would need to provide virtual care, we've been talking about this for some time. And in fact, I remember participating on a committee a year ago, and we were charged with how would virtual care look at North York General? How would we roll this out? What would we need to do to make it happen? And so we got together a group of people and we talked about, you know, who was already doing it, what we would need to invest in, what are the platforms that might facilitate this work. And to be honest, I think we were a bit bogged down by the process, by maybe a little bit of conservative views, by some reticence, of something that's not, doesn't, we haven't really done this before. But in fact, what happened next is COVID came along. And all of a sudden, we just knew that we needed to roll up our sleeves and get it done in true North York General fashion. And we did. So I think that at North York General, we're committed right from the top, senior leadership team down to the front line. We basically know that this is good for patients. Providers like it too. And it's actually led to some other sort of spin-offs like patient self-appointment bookings, access hotlines, secure messaging to patients that will flow right into the EMR of your family doctor. So there's lots of things that are happening as a bit of a spin-off to all of this. But to answer your question, after all that long-winded commentary, 60% of primary care is virtual. I would say probably, at least in our environment and from what I know, it's actually way more than that. And it grew out of a need. Patients, even though everything was shut down, patients needed to have care. But at the same time, there was a lack of appropriate, for example, office space in primary care. There was a lack of appropriate PPE, personal protective equipment for primary care offices and some specialty offices. In the hospital, those of us that have offices in the hospital, we're fortunate because we have the screeners at the front door. We have all of our policies and procedures in place. We have fantastic cleaning of our facilities. We have, everything that happens without necessarily our intervention. So we are privileged, and primary care didn't necessarily have that. But also, I could say that patients wanted this too, but they also didn't want to necessarily come to their primary care doctor's office. They didn't really want to come to the hospital. They had fear that there would be risk to that. But by the same token, there were some unintended consequences to all of that. I think patients' fear of accessing care in a personal way, in a face-to-face way, led to some unfortunate outcomes with people delaying their care, with disease progressing to a level where it didn't need to progress or wouldn't have progressed before. And so, we can talk about a little bit about that later in terms of what were the clinical implications. But I also wanted to talk a little bit about the research that we do here at North York General and the fact that we have a research program in applied research for quality healthcare delivery. That's the whole raison d'etre of our research program. And what happened to our chairs, our research chairs, is that everybody packed up and went home. So there's this whole business about virtual care and working from home that has a whole other arm of implication to the provision of care. So we have chairs in human factors, in big data as it relates to primary care EMR, in patient and family-centered care, in artificial intelligence. All of these people went home. So what were the implications of that? We can talk about that later as well. Some good, some bad. And what about our clinical trials? We have a huge clinical trials group now that's been very successful, and we were bringing on board COVID trials. All of those other people went home. The clinical trials people had to stay, and it was lonely down there. And they had to be trained to go into COVID positive patient rooms to take consents and speak to patients and speak to families about entering into clinical trials, which was a bonus for the patients. But it was hard for those individuals dealing with, an uncertain disease and an unfamiliar territory, but they stepped up and got it done. So I think all of these things are things that we can talk about later. With respect to surgery, again, I'm a general surgeon as well, and all of the offices pivoted very quickly to to virtual care, including just plain old-fashioned telephone, sometimes video conferencing, Teams, Zoom. There are some more sophisticated applications within the Office EMR that allowed for secure text messaging and so forth. So all of these things are part of what happened when we had to sort of make a major shift and just get it done. Thank you.
Yeah, it's a lot of change for a lot of different stakeholders at the same time, right? And at a very rapid pace. And so, and I think, as you said, COVID sort of accelerated what the path you were down already. So thanks for sharing, and looking forward to hearing and learning more. So thanks, Dr. McRitchie. Dr. Shin, could you take it from there and share how how we pivot in other areas of the hospital?
Sure, Nicole. To start off on a personal note, both my 96-year-old grandmother and my mother, who's I think still young enough that it probably would be very wrong to share her age on a very public house calls chat, have been able to benefit from virtual care provided by North York over the last several months. And so it's with real pleasure that I'm able to speak to the virtual pivot that the medicine program has made. Dr. McRitchie spoke about the broader hospital lens and a little bit on the surgical piece. I think I can touch best on the internal medicine initiatives that we've undertaken. And as many of you already know, medicine and the medicine program provides care in both the inpatient setting, the outpatient setting, to a wide variety of patients. And for a quick 20-second refresher on what internal medicine is, it's the area of medicine that specializes in diseases of various internal organ systems, so like the heart, cardiology, brain, neurology, or general internal medicine, which is a specialty that looks after patients who may have problems with multiple organ systems at the same time. And many, but not all of our patients are elderly, and geriatrics is another subspecialty of internal medicine that focuses specifically on senior health care issues. And so in each of those areas I mentioned, we have worked really quickly to implement virtual care initiatives. So if I can just give a couple of examples, in our Baruch-Wise outpatient care clinic, the general internal medicine physicians now see about 2/3 of their patients using virtual care. And these patients are patients who have recently been discharged from the emergency department, but still need very close follow-up investigations. Or they may be patients who have been recently discharged from hospital, and this clinic then allows for patients to be checked up on to make sure that there's been a smooth transition home, and hopefully to then prevent the need for ever coming back or to be readmitted to hospital. In our senior care area, our geriatricians between May and October, in fact, had over 3,000 virtual visits, and the clinics there are quite there's quite a variety. They range from memory clinic to a really impressive geriatric Parkinson's clinic, to our day hospital rehab program, where we can have a physiotherapist, an occupational therapist, a social worker, a physician, all in the same room. And then they can video conference with a patient and their family member to do even home exercises or to provide counseling. At our stroke prevention clinic, we have a neurologist and a nurse practitioner, and they see about 50 patients per week. About 2/3 of them are now virtual. At our Rosenberg Family Cardiac Care Clinic, we have cardiologists and cardiac nurse practitioners seeing 300 patients per month. Between 50 and 75% of those patients are seen virtually, and the disease conditions are really quite varied. They can range from congestive heart failure to new onset chest pain, to patients who have recently had pacemaker insertions. And in fact, my grandmother, for example, had a virtual visit, and she had her blood pressure medications adjusted because she had recently been seen in person in the clinic, and her blood pressure then went out of control, and she was able to access, with my mom's assistance, the cardiologist to adjust her medications. And so that is really something that is new and something that should have been easier, but we never did before. Finally, I did want to touch on the use of virtual care on the inpatient side. As Dr. McRitchie and I are both intensivists, I think it would be an oversight to not mention some of the initiatives we've implemented in the critical care unit. And at North York, I think we've long recognized that families are crucial partners in care. And obviously, all of our ICU patient care is in person, but family access to visiting during this COVID pandemic has been extremely challenging, in many ways heartbreaking. And we were able to quickly pivot to implement virtual visits, and so that patients could connect with their families. We could meet families face to face over FaceTime or using iPads, and families could see their loved ones in even the most challenging and devastating conditions. And I think our ICU has been very proud to have accomplished that very quickly. And I hope that patients and families have had at least some small amount of comfort in being able to connect virtually. Thanks for giving me an opportunity to give that brief overview, and I'm looking forward to having more conversation over the next 45 minutes or so.
Thank you, Dr. Shin. I think that the notion of people having access to certain technologies as well is probably something that's, not everybody has the same technology, right? So something to think about as you're delivering this virtual care. So thank you for that. I'm sure there's going to be lots more questions. But first, Dr. Kanani, let's chat about virtual care with the pediatric clinics, please.
Thanks, Nicole. So I think I'm going to probably build a lot upon what Dr. McRitchie and Dr. Shin have already said. In the pediatric program, even before the pandemic, we were on a journey of trying to decide how we would implement virtual care. And we had gotten a lot of the physicians set up to do Ontario Telemedicine Network. We had started doing some virtual visits, mainly for people that were from further away from Toronto, or for some of our more complex pediatric patients where it was hard to come into the hospital. But not all of the physicians were set up, and we were doing it maybe once a month. But we were set up, which was a huge benefit for us when the pandemic hit. And then in early March, when we had been doing a lot of pandemic planning, and we knew that if everything went into lockdown, we needed to continue to provide a service to our youngest patients, that we had planned that we would convert everything to virtual. I thought maybe it might be helpful just to share a story of sort of how we quickly implemented a virtual clinic even for COVID pediatric patients. So in early March, when I think none of us really knew what was going to happen in the world, we were starting to see adults with COVID in the hospital. But when there was a first pediatric patient that showed up, it was quite stressful. So it was a night in early March when I was actually on my way driving home, and the on-call pediatrician called me and said, there's a baby in the emerge and the grandfather has COVID. I'm pretty sure this baby has COVID. So I said, okay, assess the baby, find out if you think the baby needs to be admitted. He called me back and said, the baby looks great. I think we can discharge the baby home, but I think they need follow-up. So, typically we do run a pediatric follow-up clinic similar to what Phil runs with the internal medicine group. We have a pediatric follow-up clinic for pediatric patients. Generally, before COVID, they were all being seen in person. I happened to be the one that was going to be in clinic the next day, and I told the on-call pediatrician, I'll do a virtual follow-up and I'll find out how the baby is doing. So the next day, I did a virtual consult with the family, and it was extremely helpful for the family. It ended up being that both of the parents and the grandparents, they all had COVID, and they were very stressed that this 3-month-old baby also had COVID, and there really wasn't a lot described yet about pediatric patients. So, quickly I tried to reassure them, and it was amazing how much you can actually do through a virtual visit. So I sort of asked them, I said, take your camera, show me your baby. I could see the baby smiling at me. I sort of said, lift up the shirt so I can see the breathing. And I could see the baby didn't have any labored breathing. So, quickly we adapted. There's a lot you can learn by doing a virtual visit. And, I asked the family, I said, do you want me to do another check-in? They said, can you please do another check-in in a couple of days? So I said, no problem. I'll do another follow-up in a few days. A few days later, I did another check-in. The baby was doing really well, but a lot of it I found was reassurance. So, the family really wanted that input from me. And for me, it was also a chance for me to learn about what happens to a pediatric patient with COVID. So I did 2 more follow-ups, and I actually called the family yesterday just to find out 9 months later, like, how was it to have those virtual visits at a time of crisis? And the feedback from them was that it was great that they knew they had someone they could connect with virtually, because they didn't know what they were going to do if their child got sicker. Can they just walk into the emergency department? They knew they probably couldn't go to their doctor's office because of all the restrictions. So we had reassured them that if your child got sicker, we'll figure out a process where we can bring them in safely. Thankfully, that baby didn't need to come in, but the family had a lot of positive things to say about the virtual visit. So, after March, we started seeing, I mean, not too many, but we did see patients come through our emergency department with COVID, and we did continue to do virtual follow-ups. The other thing we found was we saw a lot of pregnant women who had COVID and then delivered a baby. And thankfully, none of the babies got COVID, but they required follow-up, and we needed to see whether or not the babies developed any symptoms. And in the first 2 weeks of life, usually these babies get frequent follow-up. So they're usually seen by their family doctor or pediatrician every few days to see, are they developing feeding difficulties? Do they have jaundice? So we did a lot of virtual follow-ups for those babies. And again, there was lots we were able to do virtually. And there were some that needed to come in, but the parents had COVID. So we had to think of a safe way of bringing them in, but we were able to facilitate it through our Emerge. So that actually was a really beneficial service. So we've continued to provide the follow-ups for COVID positive patients through our clinic virtually. And if they do need to come in, we have a safe mechanism to bring them in. And then in terms of other sort of pediatric services, so in addition to our general peds follow-up services, all of our subspecialty services converted to virtual visits. And a lot of them are still running virtually. So for example, our pediatric asthma clinic or our pediatric neurology clinic, they're still running virtually. They have brought in some patients who need to be seen in person, but they're still able to do quite a bit through virtual visits. We also converted our breastfeeding clinic to virtual, and that's been also going very well. So I think we've certainly made a huge pivot, and we've sort of realized over the months that a lot of things can be done virtually. There are some patients that do definitely need to be seen in person. So currently, a lot of our clinics are doing a combination of in-person and virtual visits, and it seems to be going really well. And I think that in the future, this definitely will be part of our practice, and there is a role for virtual care. And I think, like I think Donna had said, clinicians enjoy it as well, and I think it's really good for patients and families. But you just have to have limits. Like if you have a patient where you need to bring them in person, you have to facilitate that, because definitely you can't do everything virtually, but there is quite a bit that we can accomplish.
That's great. Very insightful, Dr. Kanani. So the time has come. I'm going to pass the three of you over to the moderator, Christine, and she's going to jump into some of the questions that came in from our community.
Thank you, Nicole. Hello, everyone. Our first question will be directed to each one of you. What are the benefits of virtual care? And how can you share some of the challenges that you've witnessed with virtual care in the last 7-8 months? And let's start with Dr. Shin.
For sure, I can try to start the conversation. Maybe what I can do is mention one benefit and one challenge. In terms of benefits, I think one of the key benefits is that it provides patients and families with choice. And I know that there was a Canadian Medical Association survey a couple of years ago that said that 70% of patients wanted virtual care to be an option. And as Dr. McRitchie had mentioned before, that prior to this pandemic, there was so much inertia in trying to implement virtual care. And now that we've overcome that inertia, I think this is for sure going to be an option for patients and families going forward. They may not always choose it. For example, I mentioned that my mother received care here recently. Her first visit was over the telephone. And then the second visit, she actually chose to meet her specialist in person. And so I think having that choice is really important and a huge benefit. One challenge that we've talked about as a department and as a hospital, and I think at the University of Toronto, a recent seminar I participated in, is that I don't think we've quite figured out how to incorporate learners. As you know, that a lot of the physicians here are physician educators, and we have medical students and residents with us on a regular basis. And how do we supervise and how do we teach in a virtual setting is new territory for us. And as mentioned, there has been a lot of discussion within the hospital, as well as at the university, trying to provide guidance. And I still think we have some work to do, but I think we'll find some solutions going forward for sure.
Thank you, Dr. Shin. Dr. McRitchie, do you have some thoughts on this question as well?
Sure. So I think the benefits, I think all of us probably recognize, and Phil mentioned one, but convenience. I mean, you can, have a consultation from your own home. You don't have to drive on the 401. You don't have to come in and park and walk through the snow. So it's very convenient. And if you can accomplish what you need to accomplish that way, like who wouldn't want to do that? I guess the challenges, at least from a provider perspective, is, and we've mentioned this a little bit already, is where is the balance? Where is the balance between feeling confident that virtual care is not inferior care, like it's equivalent, versus are you missing something? Is there a gap? Are you, not going to perceive some nuance that you otherwise would have during a face-to-face visit? And maybe I can just give an example. I have a patient that has advanced breast cancer, and she was concerned about some new skin lesions on the right side. And so I said, well, I'm not sure, she didn't want to come in because she's just recently had chemo. So I said, just send me a picture and I'll look at it. So the picture, this is the difference between 2D versus 3D when you see someone in person. So the picture I wasn't quite sure about, but I was concerned enough that I said, you know what, I'm not sure, let's just bring you in. It was a picture of her right breast, and the skin there were some funny lesions on it. So she came in and I examined her, and the right breast was fine, but there were these very concerning lesions on the other side, on the left side, which she wasn't actually concerned about and didn't even send me a picture of. And I biopsied those, and they came back showing recurrent breast cancer in the skin. So there was an example of a problem that the patient perceived of that I thought was probably nothing, and it turned out to be nothing on the right. And lo and behold, she had the problem on the left. So there are, sometimes we have to navigate through these landmines and use our judgment as to when to bring these patients in and when not to. And I think and when we don't need to. And I think that's the balance that we're all learning about and sometimes struggling with, that we'll navigate, and I'm sure we'll figure out. But for now, we're still learning.
Thank you for that. Dr. Kanani, any further comments on this question?
Yeah, I agree a lot of the things with Dr. Shin and Dr. McRitchie said. I think definitely virtual care can be very convenient for families. They don't have to miss work, and that can be a huge thing for families. Before, they would have to take a half a day off work, drive to an appointment. So I think there's a lot of convenience to virtual care visits. The other thing that we found is with some of our patients who are followed in the community, say by home care, or they're followed in another hospital by another specialist, we've actually used virtual care to do a team meeting where we, we'll have the family at home, the home care coordinator through CCAC, plus a specialist at another hospital for us at Sick Kids, where we would link all of us in together and talk about the patient. And I found that's been a huge benefit for us. I think in terms of challenges, I do agree with Dr. Shin that we have a lot of medical learners, and we've been trying to, sort out how we incorporate medical students and residents. We're certainly trying, and I think they're learning and they're benefiting from it, but it has been challenging trying to sort out how to do that, and also staying on time, because if you have a virtual care appointment booked every half an hour, and if you have a trainee, you have to make sure that you're staying on time and that you're being efficient, because it's not like someone's waiting in a waiting room in your clinic, they're waiting online for you. So sometimes we've had to get our secretary to call the family saying, look, we're running a little bit behind, tell them we'll be 10-15 minutes late getting on the virtual call. But I think it's important that we have to stay on time. So we're trying to work on that. The other thing for us is we deal with children and adolescents. And when you're trying to see an adolescent, and if there's a sensitive issue, I think confidentiality can sometimes be a difficult thing when you're doing a virtual visit. Often their parent is at home and you can't talk to them alone. We've certainly tried to say, can you go to a different room and ask your parent to leave? But it's hard to know, like, is the parent listening in? I had one teenager recently tell me, well, my dad's in the next room, but I think he's listening at the door. So again, that was a teen where I said, you need to come in and talk to me so I can talk to you alone. So I think those are some of the limitations. I also agree with what Dr. McRitchie said about if someone has a skin lesion or a rash. I've also had parents email me photographs of their children's rash, and sometimes it's easy and I can sort out what's going on, but other times it's really hard to tell, and I've had to ask them to come in.
Very good. This is a question that's come in live from the audience that since we're talking about benefits, does virtual care save the hospital money? Do you have any initial thoughts on that? I'll let anybody take that question.
I mean, I think I can maybe start off. I mean, I think in terms of booking the appointment, I think what we found is it actually ends up being more work for our administrative staff because they have to contact the family, they have to get their email address, they then have to email them the appointment, they're calling them for reminders. So I think from an administrative perspective, I don't think it's really saving us. I think if anything, it's adding a little bit more to their workload. I think in terms of physician compensation, the billing is now the same whether it's virtual or in person. So I don't think it's saving anything that way. I'm not sure if Dr. McRitchie or Dr. Shin have anything else to add about if it's saving us money.
Yeah, I would say it probably hasn't been at top of mind for, I would say probably for the three of us. But I think one thing that is exciting would be that it does potentially free up space. As everyone knows, hospitals are always looking for new spaces and ways to use spaces efficiently. And if we do more virtual care, then perhaps we can really start to rethink about what spaces are needed in the future going forward with healthcare, and that in some ways is a financial issue that we can use our space in ways that are really going to benefit our patients in the future going forward.
So I would say with my corporate hat on, for sure it's more patient-centered, but in terms of cost, it's actually costing the hospital money. It's not neutral, it's actually costing us money because, and this may sound a little bit crass, but the patients aren't coming and parking here. So parking revenue, believe it or not, is a huge dollar amount that contributes to the operations of the hospital. Like those dollars that we used to make from parking, and we used to make from our food services for patients and families that would come in to visit, they've all dried up now. So those would go back into supporting programs and services that would go back to serving our community and our patients. So that's not happening anymore. So in fact, it's not good for the budget of the hospital. It's great for patients, and that's why we're doing it, but it's not good for the budget.
Very good. So we're going to move on to another question. This is for Dr. Shin. The older generation may not be as tech savvy. That's a mass generalization, of course, as some of the other community members. How do you work around this?
It's a common concern. I would say that it's not just for the older generation. And I think prior to the pandemic, many of us, physicians included, thought that virtual care meant high tech, or there was going to be need for more sophisticated technology like fancy video screens and conferencing. I think one of the biggest lessons that we've learned is that a lot of virtual care can be done by telephone, and that's a technology that everyone knows has been in place for over 150 years. And in fact, most of the virtual care that I talked about in my opening remarks has been done by telephone. Having said that, we do need to be mindful to make sure that virtual care is accessible to everyone, not just the elderly, but also patients whose first language isn't English, or those with physical disabilities like hearing impairment. And there is the danger that if we don't think about and prioritize these patient populations, then virtual care may be, in fact, exacerbating healthcare inequities rather than making it more accessible. I do know that some of the video options have increased markedly over the last number of months. Prior to the pandemic, we really essentially had only one option that wasn't really appealing to many of us. And now, just over the last number of months, there have been many options that have sprung up that are secure, that are safe, that have closed captioning, that have even abilities to connect family members much more easily. So translation, closed captioning, hearing impairment, all of those things can be addressed, and they're becoming much easier to use. And so that tech savvy piece, hopefully the need for the tech savviness will decrease over time.
Great, thank you. Moving to the next question, Dr. Kanani, how is it determined who's a candidate for a virtual appointment versus someone that you must see in person?
Yeah, so we triage a lot of our referrals. In terms of the emergency department follow-ups, usually those we're booking as a virtual follow-up because they've just been seen in the emergency department and they would have been examined by a physician. So we found that those are usually very easy for us to do virtually. And then once we see them, if we're concerned, then we bring them in for an in-person visit. So that's what we do for the emergency consultations. In terms of other visits, we look at the referral with our clinic nurse, and one of the physicians will triage it. And it really depends on what the complaint is, and then we decide whether or not we think it can be done virtually or in person. We've also found that if we do it virtually initially, we've taken a lot of the history, and then if we do still need them to come in for an in-person visit, that in-person visit is very short because we already know the history, and really we're bringing them in for a physical exam or for lab tests or for diagnostic imaging, and we already know the story. So I found that that's really beneficial, even if I've done a virtual appointment initially. And then I say, you know what, you need to come in 2 days. You're going to come in for some blood work. I'm going to do a physical exam, and then we'll talk about what we think is going on. I think that mechanism has actually worked really well. So as long as and then there also are some consults where you do it virtually and you're able to come up with the diagnosis, make recommendations, and you don't have to bring them in. So it's kind of a combination, but we try our best to determine who we think would be best seen virtually.
Great, thank you. Dr. McRitchie, someone has mentioned that they've seen in the news that there's an Ontario hospital doing emergency room visits virtually. Could North York General do that, and how would that work?
So absolutely. There is a sort of a pilot study of a couple of hospitals that are partnering together to try and work this out. We've talked about this before, and we've all thought, wow, what a great idea, and we could do this. And now we're thinking, not only could we do this, we probably should do this. So how would it work? It would be, instead of having a shift of emerge docs looking at patients in acute and subacute and ambulatory portions of the emergency department, they would be assigned to the virtual booking clinic, if you will. And so patients would access a common booking system electronically. They would book their appointment virtually, and an emerge doc could probably even be from home and coordinate and consult on the patients that had questions or problems that would otherwise come physically to emerge. So yes, that's a possibility for sure. And we're actually looking at that because we think it's a great idea.
It sounds very exciting. Dr. Kanani, there have been a couple of comments that came in advance that have stated, now that things have gone virtual, wait times have decreased. Can you share your thoughts on this?
I think at the start of the pandemic, a lot of doctors' offices had closed and were only doing urgent sort of referrals or seeing patients urgently. So I think we were able to catch up back in the spring because we had continued virtual care. So I think a lot of our specialty clinics did see a decrease in the wait times. I think in the summer things picked up again, and certainly we were getting similar numbers of referrals. So I don't know if it's for sure decreased wait times. I think for some of the clinics it may have, and we've become a little bit more efficient, especially with follow-ups. I think we'll have to see over time as we get more used to this. It may decrease wait times, I think, especially for follow-up visits. I think you can do follow-up visits very efficiently virtually, but I think we haven't found that for sure it's decreased wait times. I don't know if Dr. McRitchie or Dr. Shin have seen other trends with wait times.
Yeah, Donna, do you want to go ahead or?
Oh, go ahead, Phil.
Yeah, I was going to say, I think it's really early to know. I do know that a lot of the comments from the physicians is that there's quite a bit of work in preparation for each appointment, and sometimes the appointments actually have been taking longer, and so some of the convenience and access where that creates efficiency and perhaps can decrease some of the wait times can be balanced by the fact that perhaps less patients in fact can be seen because the actual consultations are taking a little bit longer. I do know, I remember that the chief of psychiatry mentioning that mental health wait times have been addressed effectively with virtual care. So I think the jury's still out at this point. I'm not sure, Donna, if you feel otherwise from surgery or other areas.
Yeah, I think it's probably quicker for patients in terms of they don't have to drive, they don't have to park, and so on, like we've talked about before. But I'm not so sure it's actually faster for the care provider because of the things that you've already mentioned. So I think you're right. I think the jury's still out.
Very good. Listen, Dr. Shin, a question for you. People want to know if their virtual care is safe and secure from a privacy perspective.
Sure. I think Dr. Kaneni touched on it briefly. I can maybe expand a little bit. And I think the main message about privacy that I would want to communicate is that on the physician and hospital side, that there has been a lot of emphasis on ensuring that the virtual care that we are providing is safe from a privacy perspective, and that physicians have been very methodical in their approach to it. And it's not just another phone call, because we know that phones and video conferencing cannot be 100% safe. And so we've done a number of education sessions and to ensure that the correct process is being followed. Maybe a couple of key points I could share. Number one is that physicians are getting explicit consent for each and every visit with every patient and explaining what the limitations of virtual care can be. Number two, I think Dr. Kaneni mentioned this, but we really work to ensure that both the physician and the patient are in an appropriately private location, that these discussions aren't happening in public locations where others can hear. Number three, we really make sure that we're speaking with the right person. So if it's over the phone, then we may ask questions to verify identity, or if it's video conferencing, we'll ask them to hold up their health card to the camera to ensure that we're speaking with the right person. And then number four, we document really carefully who is present. We ensure that other people aren't listening, and then we inform and we're very clear with patients who is present on the hospital side. If there's a supervisor, if there's a learner, if there's another member of the staff who is privy to the conversation. And then I think finally, it's important to say that, like we've been saying all along, that if patients are not comfortable with this, then we should always give them the option of an inpatient or in-person visit, that there should always be choice, and there may be times where it's very appropriate to be doing things in person rather than virtually.
Thank you. This is a question from our listeners. Has the move to virtual care improved the follow-up of patients after ER visits?
I can start by commenting. I think that for ER follow-up patients, I mean, we always had a process both with the medicine program and with the pediatric program and surgical program. We have follow-up clinics in the hospital. I think that with the virtual visits, it's definitely made it, like it's enhanced it, and I think it's more convenient for families. We did sometimes find before the pandemic that some patients wouldn't show up, and we didn't know how were they doing, and we'd sometimes would call them, or our secretary would call them, and there'd be that question like, how are they doing? But I think with the virtual platform, whether it's a telephone call or a video call, you're able to touch base with that family, close the loop, make sure that the family or child is doing well. So I think, in my opinion, I think it's improved the care, and we certainly have found in pediatrics that it's really helped us to do proper follow-up of these children, and then we transfer them back to their primary care physician once their issue is resolved.
I would say the same on the adult side. I mentioned in my opening remarks, the Baruch Wise Outpatient Care Clinic is where emergency department follow-up for internal medicine occurs, and I think about 2/3 of the care is virtual. In fact, we've created a new rotation of a physician who's exclusively doing virtual care follow-up for these patients, and so I think access has been improved. And because these patients have been examined in person in the emergency department, we do think that we can do it safely. So I think that there have been definite positives from an emergency department follow-up standpoint.
Thanks,
So
Dr. Shin.
sorry, I was just going to say, Christine, same for general surgery. We use our clinics to follow up, and they're often virtual. And I would say that there was a system in place before, and there's now a virtual option, and that's been very successful.
Dr. McRitchie, what is the difference between telehealth and virtual healthcare?
Okay, so that's a good question. It's a tough question. Telehealth, telemedicine, virtual care. It's kind of complex. I think I'll throw this over to Dr. Shin. No, I'm just kidding. I'm just kidding. Phil, you can comment on it if you want, but
I was about to have some technical difficulties.
oh,
Well,
he faded to black. Okay.
yeah, no, well, the quick comment I would have is that capital T telehealth, as everyone knows, has been a system that's been in place in the province for some time, where patients were able to call a central number and get some guidance from often a nurse to provide to talk about what they should do for next steps. I think when we're talking about our conversation tonight, this is leagues beyond where we were. We're talking about using it for every discipline, for every type of situation, whether it be, now we're talking about even emergency department visits, follow-up visits, different pediatrics, internal medicine, surgery. And so I think that's the way I'd at least maybe start the answer, that this is telehealth on steroids, and then to the exponent 3 or 4 or 5.
So that was very good of you. I honestly didn't expect you to answer it, but thank you so much for doing that. Well, so let me try. I probably won't give you as good an answer as Phil just gave you off the cuff, but so telehealth is the use of electronic information and communication to support long distance care. Now, if it's telehealth, that is care, clinical care. It could be public health. It could be education. It could even be health administration. If it's telemedicine, then that is the same, supporting clinical care, which is essentially virtual care. I mean, virtual care just means not in person, essentially, and often the use of some kind of technology, and it may be even very rudimentary technology like the telephone to provide care. But I appreciate Dr. Shin's input into this.
Thank you both. Dr. Shin, this question is for you. How is virtual care being delivered in long-term care, in a long-term care setting?
Yeah, so long-term care, as you know, has been really catastrophically and tragically affected by the COVID pandemic. And one initiative that we started in mid-March at North York General was at the beginning of the first wave, when it became apparent that long-term care residents were being disproportionately affected by COVID. And what we did at that time is we set up a virtual care option to support long-term care physicians and staff. So general internal medicine, palliative care, and our nurse practitioners provided support. We were on call, and we were able to provide assistance to long-term care physicians and nurses, as I mentioned, to see if these patients could be managed safely in long-term care. And we were really in contact with all the long-term care facilities in our catchment, as well as our retirement homes. Or sometimes they needed to come to hospital appropriately. And so that was the service we provided. I think it has morphed, and there is a GTA-wide initiative called LTC Plus that is really looking to formalize the structures of this, and North York is very much involved in this. And I think we certainly hope that the virtual care benefits of this initiative will extend far beyond, and when this pandemic is long over.
Thank you very much. Next question is for Dr. Kanani. How have you integrated virtual care when setting up appointments, ordering prescriptions, and is there a seamless interface with other care providers?
Yeah, so I mean, in terms of setting up the appointments, a lot of it's done through email. So when we get a referral, the secretary will call the family initially and get consent to communicate via email. And then if we're doing a video call, the secretary will email the link to the video visit. So definitely we use email. And there is a little bit of back and forth. Like if they want to reschedule the appointment, they can utilize email for that. In terms of prescriptions, what we do is if we have a virtual visit and we need to give a prescription, we can fax the prescription to a pharmacy, or we can even phone the prescription into a pharmacy. In terms of communication with other care providers, so we have an electronic medical health record where we document our visit, and then it automatically gets sent to the primary care physician and the referring physician. It also goes into a central repository called Connecting Ontario, where anyone can actually view that note. And for pediatrics, we have a separate EMR called Electronic Child Health Network, so it also goes into that repository. So there's lots of mechanisms where people can see what we recommended. And we use email for booking the appointments, and like I said, fax and telephone for prescriptions. So I think we're using a number of different tools to provide the comprehensive care.
Very good. Perhaps all of you could share your thoughts on what you see in our future and if virtual care is here to stay. Dr. McRitchie, would you like to go first, please?
So I think probably by the tone of the conversation that we've already had this evening, I think you could figure out that it is here to stay. I think patients and actually ourselves, like if we think of ourselves and how we would like to access our own healthcare, I think we would all prefer that. People are busy, they have other commitments, they don't necessarily want to drive and pay for parking to come and visit a healthcare provider unless it's absolutely necessary. So for sure, I think it's here to stay. And as I alluded to previously, I think the devil's in the details in terms of the balance between the virtual visit and the in-person face-to-face visit. And when do you need which one?
Any other comments from Dr. Shin or Dr. Kanani?
Sure, I think we all agree on the here to stay piece. I think going forward, we may start to see some more sophisticated technology, not necessarily more difficult to use, but for example, our cardiology team is about to begin participating in a clinical trial that looks at a mobile phone app that will help patients manage congestive heart failure. So one nurse, for example, will be able to monitor 300 patients. And in fact, there will be some artificial intelligence or AI technology that will then guide patients depending on what data they input in terms of what medications to use, what doses to use, and when importantly, when to seek help directly. So I think the future does seem very exciting, and I think our hospital will be a part of it for sure.
I also agree. I think that there's huge benefits for virtual care, but I think we just need to know our limitations. I think, we certainly have seen some cases where, a baby or child has had multiple virtual visits and then they finally come in for an in-person visit and we find something different. So I think that there's definitely a role, but we have to know our limitations. So I think a combination of in-person and virtual and knowing when it's appropriate to do a virtual visit versus in-person is what we'll look for in the future. But I think it's obviously been a stressful past 9 months, but we've learned a lot about virtual care. And I think in some ways it really pushed it forward because we were talking about this a lot in our hospital last year when we were talking about strategy. And slowly different clinics were starting to do a little bit of virtual care, but certainly we were forced to do it in March. But I think there's going to be a lot of long-term benefits to this as long as we know our limitations.
We have a question coming in from live from our community. What technology, we're all using Zoom tonight, but what technology do you use for your virtual care, and how do patients learn how to use this technology if it's not a common one?
I can maybe start. I mean, certainly the one that we were using the most was Ontario Telemedicine Network. I think that the issue with that platform is sometimes it is difficult for patients and families to use. There is an app that you have to download, and certainly when I've used it myself, there are some families that find it difficult or they can't log in. Our secretary does try to help families understand how to use it, but I've definitely had scenarios where they have trouble. At North York, we also have another sort of platform we can use called Microsoft Teams, which is another platform that some people have been using, and it's secure, and we feel that's another safe way of using it. And then different private offices have their own EMRs set up through their private offices. So there are a few options, and I think if you're failing to connect with them virtually, you can always phone them. So there always is that backup of telephone call, but certainly those are the platforms I think that we're generally using.
Great. Yeah.
I have a question that anybody could take. Has the use of virtual care created an advantage with linking with family physicians and other specialists?
I mean, I'm not so sure it has. Maybe others have a different opinion, but I mean, I think we were pretty good at communicating our consultations and our notes with others. So I'm not so sure it has.
One piece just to follow up that Dr. Kanani had mentioned Microsoft Teams. Within the hospital, when we use it, we can actually, it has simplified contacting different physicians that we are able to use a secure messaging system within that just to speak with each other. So if we're looking for different specialists throughout the hospital, you don't necessarily need to know their cell phone number or to use the hospital switchboard. There are ways of communicating. Whether that gets expanded going forward, I think it's still early days. So within the specialist network or within the hospital, that's been helpful.
Yeah, and I think in terms of linking family physicians with the pediatricians, I mean, we have a very good relationship with the family medicine department. I think, and they always would be sending us referrals, but I think with the virtual platform, some of the referrals we know we can do by telephone or virtual. So I feel like we are getting some more referrals from the family physicians because they know that the child may not need to come in person and that we can connect by telephone or virtual means. And I think the families appreciate it because they've gotten an opinion from a specialist without actually having to leave their home. So I think, over time, some of those, it might have just been a phone call between a family physician and a specialist, and then the family physician was relaying that back to the patient. But with virtual care, we can actually talk to them ourselves, and they can hear from us that, we agree with what your family doctor is doing, or this is what we think you should do. So I think there will be long-term benefits to that without having to make a family actually come in to see a specialist. They can do it virtually.
I think just a brief
Question,
comment. Sorry, Christine. Just a brief comment on the communication amongst the physician group with these platforms. It's improved it tremendously in terms of our meetings, our rounds. We are finding that things are so much more efficient. Things start on time, they end on time. The participation is so much better because of the ease of accessing, the electronic platform versus coming into the hospital and doing it in person.
Very good. We have another question from our audience. If a family member's patient is in the ICU or admitted to the hospital, can a family member visit the family? Can they visit each other virtually?
I can start, and then obviously Dr. McRitchie can add. So we have both options. I think that we still are important to know that families can still visit patients in the ICU. We do have some specific guidelines to make sure that patients are kept safe and visitors are kept safe, and that access unfortunately is not as open as we would like, but we did learn during the first wave where access was much more restricted, the devastating impact of separating patients and families. Importantly, throughout this whole pandemic, we have had a virtual visit initiative through the hospital, including the ICU. And just to put in a word for our ICU social worker who has worked tirelessly to connect patients and families virtually when it wasn't an option. If patients with COVID, as I mentioned, had special isolation or family members, it hasn't been uncommon for them to be sick. Virtual is for sure still an option in the ICU. Did you want to add to that?
Nothing to add, Phil.
Just this is going to be our last question for the evening, and it's really not about virtual care. It's something that's on everybody's mind. And do you have a point of view about the vaccines that are obviously getting moved into the province and across Canada and I guess across the world? Maybe Dr. McRitchie, would you like to talk to that?
Sure, I'd be happy to. So I think all of us who have seen COVID patients come in, get sick, get sicker, call their family and say, I'm going to get intubated and put on a breathing machine. understand the devastation that this disease can have, even in young, healthy people. So I don't want to get COVID. I don't want you to get COVID. And you know, I think that the risk of a vaccine, even one that's new, is way less than the risk of getting into trouble by contracting COVID. And I would just hope that everyone takes advantage of their opportunity when it comes to vaccinate.
Thank you so much. I think we're going to turn it back to Nicole.
That's great. Thanks, Christine. Wow, the hour flew by actually. So thank you for sharing all your expertise, which has really helped shape a great conversation. Dr. Shin, Dr. McRitchie, and Dr. Kanani. Are there any best practices or quick final words that you'd like to share before we close out for the evening?
Maybe I can just start, Nicole, by saying thank you again to you, to the people that came on the call tonight on this program. I hope that we've provided some information, some hopefully valuable information. And I just want to make sure, and I hope my wish is for everyone to keep safe and be kind to each other.
That's great.
Yeah. And as much as I think all of us love patient care, I think it would be highly preferable if none of us had to look after any of you, either in person or virtually for that matter. So I think key messages are really to stick to the basics. I think the messages coming from the media and social media are just really overwhelming. So the basic things are to wash your hands, to wear your mask, and as difficult as it will be in the coming weeks, that to really keep your interactions to within your immediate household. I think the hospital system and ICU capacity is under enormous strain, and the next month will be very, very difficult. And we really would like everyone to remember some of the basics to keep yourselves safe.
Thanks. And Dr. Kanani?
Yeah, I would agree with what Dr. Shin and Dr. McRitchie are saying. For those of you who have young children, just remember to enjoy the holidays in the coming weeks and just be creative. Do things virtually, make it fun. Reassure them that the world won't be like this forever. Things will get better. I know it's been a really hard year, but I think just stay positive, but stick with your own household and just do things virtually. Try to connect with grandparents, relatives through virtual visits, and just remind them that the world will get better.
That's great. Thank you. Thank you to all three of you. I'd like to thank our community and the physicians for shaping this conversation this evening. You've helped inform others as we navigate the present and actually ready ourselves for the future. In the next few days, a link to this recording will be sent to you along with a short survey that will help us plan for the next house calls. So from our house to yours, be well, stay safe, and have an enjoyable holiday season. Thank you and be well.